Okay, so this is a pretty fitting upcoming case of mine for next week. She's a 16-year-old female competitive cheerleader who had an instability event during practice. She has an ACL tear, and it's also a rather obvious case of a ramp lesion when you see it rather clearly on the MRI images. So there's a tear of the posterior aspect of the medial meniscus with some surrounding bone edema. An important point about these ramp lesions that we'll discuss a little bit later is that they're not always quite so obvious, especially on the MRI. So before I started really looking for them, I probably missed some of these lesions. Now I have a very high index of suspicion whenever there's some posterior medial bone bruising or high signal in the medial meniscal capsular junction in this area, especially in the setting of an ACL injury. And this brings me back to the quote Anil just brought up from the elder Dr. Ranawat, and that the eyes only see what the mind knows. So ramp lesions certainly fall into that category. So we'll start with a little bit of anatomy, which I'm sure everyone knows, but the medial meniscus body is attached to the tibial plateau by meniscotibial ligaments, and these render the medial meniscus less mobile and thus more prone to tears with deep flexion and rotational trauma, such as an ACL tear. And so what exactly are these ramp lesions? Well, the literature would say there's no clear definition, but the proposed theories include meniscotibial ligament tears or other tears of the peripheral meniscocapsular attachments. And they're important, especially in the setting of ACL injuries, because they cause pain, dysfunction, and altered knee kinematics, especially when they're unstable tears. So this is the classification system for ramp lesions. Type 1 are meniscocapsular lesions. It's a little bit busy, but type 1 are meniscocapsular lesions that are very peripheral and mobility at probing them is low intraoperatively. Type 2 are partial superior lesions, and these are usually low mobility at probing as well. Visualization of these can be tough, as can that of the type 3 lesions, which are partial inferior or hidden lesions. And again, these should be evaluated for mobility and instability at the time of surgical intervention. Type 4 is a complete tear of the red zone, and type 5 is a double tear of the meniscocapsular junction and then more anterior part of the posterior horn of the meniscus. So the prior case that I had shown was a pretty clear case of a type 4 lesion, which is a complete tear in the red zone. And this is something that very likely will need to be fixed in order to restore the posterior medial stability. But the question that I always have with these type of lesions is that always the plan for these? And how do you visualize them? And what exactly is the appropriate treatment for all of these different kinds of ramp lesions? So this was a paper that was in JBJS British evaluating the association of ramp lesions in the setting of ACL injuries and found an incidence of about 9.3%. Other papers have noted an incidence as high as 17%, but this paper shows that MRI is not always reliable when it comes to evaluating or ruling out meniscocapsular injuries or ramp lesions, because none of the ramp lesions were identified in this series on the preoperative MRIs. And one of the dominant theories about why they're not identified on the MRI is that the meniscocapsular distance is reduced when the knee is placed in full extension for the MRI. So you have to have a very high suspicion that there is a ramp lesion, especially when there's some posterior medial bone edema present on the MRI or anything suspicious looking in that area. This is another paper from Liu and AJSM that looked at the risk factors for ramp lesions in patients with ACL tears. And they found that there's a higher prevalence in males compared to females. There was a higher prevalence in patients younger than 30 years old, and the prevalence of ramp lesions was increased with time from injury up until 24 months when it plateaued. So chronic ACL tears increased the risk of ramp lesions. And then a second paper out of HSS published in KSSTA showed that another risk factor was contact mechanism of injury. And this paper highlighted the importance of the posterior medial tibial bone edema in these ramp lesions. So now that we've got a high suspicion for ramp lesions, we need to visualize them during arthroscopy. This area of the posterior horn of the meniscus has been termed the blind spot, and it's not always easy to visualize with our standard arthroscopic portals. So Sangeet Katet described a four-pronged approach to identifying and treating these ramp lesions, which includes step one of making your standard anterior portals and visualizing the medial compartment. Step 2 includes exploration of the posterior medial compartment by advancing the scope under the PCL through the notch for posterior medial access. Step 3 is creating a posterior medial portal, which you can use for viewing and also for working if necessary. And then step 4 would be the repair of the meniscus if it's indicated. So when viewing from the standard anterior portal, it can be important to do an MCL release for better visualization and treatment. This is a technique that some people do for pretty much every meniscus case, especially in the medial compartment. And so the top 2 photos show a potential ramp lesion, which the MRI clued us into based on posterior medial bone edema. And then the bottom images are from anterior visualization after an MCL release, which can actually be very important to visualize that posterior aspect, especially when viewing just from your anterior portals. It can also be helpful for repair so that you don't damage the cartilage. So I think this paper is actually really important because it tells us what the optimal treatment for ramp lesions are. And the question is, do they all need to be fixed? And are we doing any harm by placing sutures in stable partial tears? And this, so this group from HSS looked at 162 patients with median 2-year follow-up to determine if all ramp lesions need to be repaired. They evaluated the meniscus from standard anterior portals with probing. 31 patients had unstable ramp lesions that were treated. 36 patients had stable lesions that were not treated. Overall, the ACL revision rate in this group was 4% and unchanged between the groups. The unstable repair treated group had a significantly higher reoperation rate for meniscus pathology than both the stable group and the no meniscus pathology group. And there were no differences in the reoperation rates between the stable untreated ramp group and the no meniscus pathology group. So the diagnosis of ramp lesion is important and the determination of stability is also important, but treatment needs to be limited to those that are truly unstable, as stable ramp lesions do not need to be repaired and will still have success. So we're all quite familiar with some of these approaches for repairing of ramp lesions, but because they're similar to other meniscus technique repairs. So there's an all-inside technique that we're all familiar with, which may require the MCL release. There's an inside-out repair option utilizing a posterior medial approach. And then there's a technique utilizing a posterior medial portal and a suture passer. So this is just one case. This has the hallmarks of a type 4 ramp tear. On the MRI, you can see the bone edema, and you can see a high signal within the medial meniscocapsular junction, so either type 1 or type 4. And then the arthroscopic pictures clearly show an unstable medial meniscus ramp lesion, which was fixed with 5 vertical mattress sutures, both on superior and inferior aspects. So this sort of highlights the importance of using an MCL release technique and doing an all-inside approach from the anterior portals. These are just some scope pictures that I found in a good article reviewing ramp lesions in OJSM, looking through the notch view with a posterior medial incision. And then lastly, these are the scope photos from Sonnery Cotette's paper looking through the notch while utilizing a curved hook suture passer from a working portal posterior medially to repair the ramp lesion. So there are various techniques, and the question really is to visualize it and then also to repair it with the appropriate technique. So that was a quick rundown on ramp lesions, which I think are quite important, but to conclude, they are tears of the posterior medial meniscus structures. They are sometimes difficult to visualize on the pre-op MRI, so you have to have a high suspicion, especially with younger contact sport athletes and posterior medial bone edema. They are in a blind spot of arthroscopic evaluation, so you have to look carefully and thoroughly and not be afraid to go into the posterior medial aspect of the knee. Not all of these ramp lesions need to be treated, but all should be properly diagnosed and evaluated for stability. Repair type is based on instability, surgical preference, the size of the tear. And then importantly, we all know that there are reoperation rates for meniscus tears, unfortunately, and that includes these ramp lesions as well. So I think that's all we have for ACLs and ramp tears.